Welcome to today's 3M Health Information Systems webinar. My name is Jared and I will be your host. We would first just like to start off by saying that we greatly appreciate your attendance today during this sensitive time in our country and across the world. In light of the circumstances, the majority of our team members are working from home today, so if we do have any technical issues during this webinar, we apologize in advance and we'll work to get them sorted out as quickly as possible. In today's webinar, we'll review best practices for documenting surgical complications. We encourage you to ask questions through the presentation. You can do this by using the questions feature in the web meeting controls, which is located in the lower right portion of your screen. We are recording today's presentation and a webinar archive will be available. So look out for an email within the next week that includes a link to the archive. A PDF that contains all of the presentation slides is available for you to download, and that's located in the Handouts section of your web meeting controls. We'll also provide a certificate of attendance to webinar attendees, and that will be emailed to you upon the completion of this webinar. Today's presenters are Cheryl Manchenton and Audrey Howard. Cheryl has been a nurse for more than 31 years and has worked in the clinical documentation integrity for over 11 years. She's currently a senior inpatient consultant for 3M Health Information Systems. Audrey has more than 25 years of experience in health information management. During her professional career, she has worked as a coder, DRG technician, coding supervisor, and assistant director for an acute care health information management department. Audrey, I know we're all excited to get started, so I'll turn the time over to you.
Thank you so much and welcome everybody. I am glad that you're joining us for the next hour to discuss surgical complications and the documentation related to such. During today's presentation, we will discuss ICD-10-CM codes available and explain their impact on quality outcome measures. In addition, we will discuss provider documentation surrounding surgical complications and how to clearly and compliantly query for clarification. Before we begin, I would like to ask a polling question, and so that should be popping up on your screen. The question is, surgical complications may impact which of the quality metrics? External profiling, organization performance, hospital-acquired conditions, or HACs, patient safety indicators, or PSIs, potentially preventable complications, or PPCs, and then all of the above. So I hope everybody has had some time to answer this question. And Jared, do we have the results on that?
Yes, I'm going to launch the poll now. Share that. Okay. So 2% said external profiling, 4% hospital-acquired conditions, 4% patient safety indicators, 2% potentially preventable complications, and 97% all of the above.
Wonderful. And yes, the answer is all of the above. It is surgical complications and the codes that are related to that are looked at in many different avenues, arenas, and so it's all of them. It could impact on each of these different areas, and that is kind of what we are going to be discussing during today's presentation. Before we get into it all, we're going to talk a little bit about the codes that are available related to postoperative complications or even just surgical complications. So this slide is kind of indicating some of the complications that are related to a device. First of all, if a device is inserted and it is not functioning properly, then it is considered a mechanical complication. And you'll see here some of the types of mechanical complications. So something has gone wrong with the device, breakdown, displacement, leakage, etc. So something has gone wrong with the device. The other types of complications that may be related to it are the body's reaction to the device. For example, you'll see here infection. So that's the body is having an infection due to the device. You'll have an instructional note on here regarding the an additional code to assign if there is an infection. What type of infection is it? And so, for example, if they have sepsis, that's related to the device. Excuse me, you're going to put the complication code, the infection due to the device, as the principal, followed by the sepsis or the infection code as a secondary. And then also, what other types of body's reaction to the device? It could be that an embolism or a thrombosis is related to the device. And so those are different types of codes that are available. Now, many of the complication codes in ICD-10-CM are classified to a T code. And so that's what you're seeing on here. The different categories within the T code range starts at T80 and goes up to T88. And so these are different types of complications. It could be due to a device, the postoperative infection are included in here, and you'll see that they're kind of broken up by where the device is located. Is it orthopedic? Is it cardiac? Is it genitourinary? So there are different codes, and basically there are just a lot of codes that are available, and it really does depend on what type of a device and what kind of complication you are having. But in addition to the T code range, there are also complication codes that are available within the body systems throughout ICD-10-CM. And what you see on this screen are all the different locations that they could be located. That could, in the spleen, the endocrine system, and going on down, you'll see nervous, cardiac, respiratory. So there's a lot of different categories of codes that are available within each body system. You'll see on this one that this includes, the title of it mainly is going to be intraoperative and postoperative complications. The code that you see on the end is the category code where it is located. For example, I-97 is where all your intraoperative and postoperative complications of the circulatory system are located. Within those body system complication codes, there's several that are commonly throughout all the different body systems, types of complications that are available. For example, accidental puncture and laceration. That's going to be within each body system. So it will matter, where was the accidental puncture or laceration, and then what type of procedure was happening when that occurred, and that's going to be how the basis of the code that you assign. They also have codes available for intraoperative hemorrhage and hematoma, as well as post-procedural hemorrhage, hematoma, and seroma. In addition to those commonly seen ones throughout all of the body systems, there are also specific complication codes that are available within each body system, but it's going to be specifically for that body system. So you'll see cerebral infarction, a complication code for intraoperative or post-procedural cerebral infarction, post-procedural cardiac arrest. And these are just some of the common examples. There are other ones that are available. So the point of bringing this all up is that we do have specificity for code assignment regarding what type of complication is documented in the record so that we can assign a specific code to it. At this point, I'd like to turn the presentation over to Cheryl, and she's going to talk about the implications of incorrect code assignment of the complication codes.
Thank you, Miss Audrey, and hello, everyone. Nice to speak with you all today. What's the big deal? Well, first of all, when we talk about those hospital-acquired conditions or HACs, if you look down this list, there are a fair amount of these that are actually are procedural related. There are very few that are not due to a procedure, such as our pressure ulcers or our falls and trauma. Like I said, a great deal of these are actually on or around that word post-op or due to devices. So our documentation really needs to be very specific and very accurate so that we are appropriately classifying them and reporting what we should be reporting. In addition to our HACs that we have, which decreases our reimbursement on a case-by-case basis, we have our patient safety indicators, our PSIs. And again, when you look through this list, you see a similar pattern, that there are a fair amount or majority of these are actually related to operative episodes of care, or, in the peri or postoperative episode of care. So as we know, these PSIs are also used as a component of the hack reduction program, and were a part of value-based purchasing and will be brought back in fiscal year 2023. As we know, what happens with this, what are these implications? This data is very transparent nowadays. 20 or 30 years ago, when I first started practicing, there was this, thing that you logged onto at your hospital. You reported an adverse effect, and it was really underutilized, and it went into some deep, dark hole that we didn't hear about. Today, it's very easy to find out information on any hospital's complications through a few easy searches, including on the hospital's website. They are even being transparent on their complication rates. Do realize that all of our claims data is actually filtered into a giant system called MedPAR data for our Medicare patients, but there's also the HCAPS, which is the commercial payer files, which, again, anybody can purchase those data sets and use them to analyze our complication rates. We know very clearly that third-party payers are using those. And as kind of a gentle reminder, or maybe a duh moment for most of us, complication of care is one of our most reported measures, indicators of quality. Whether or not it's the best measure, I think we can have lots of debate and discussion about. Whether or not it really has all this reporting really reduced medical errors, yes or no? That's certainly open for debate, but we do know that it is very reported.
And I'm going to talk a little bit about coding guidelines related to the complications. First of all, we have this first guideline is related to the sequencing of a principal diagnosis. Remember that the definition of the principal diagnosis is that condition established after study to be chiefly responsible for admission to the hospital. So if a patient is admitted to the hospital because of a complication, or because of a condition that is documented as due to a prior procedure, then the principal diagnosis will be the complication code. The code for the specific condition can be sequenced as a secondary code. For example, if a patient is admitted due to cellulitis from an operative incision site after a total hip replacement, the postoperative infection complication code will be sequenced first, followed by the cellulitis code as a secondary diagnosis. The secondary diagnosis code is identifying that the infection was cellulitis, so it's providing additional documentation or additional specificity. The next coding guideline is related to the actual cause and effect. So please remember, as with all procedural or post-procedural complications, code assignment is based on the provider's documentation of the relationship between the condition and the procedure. Not all conditions that occur during or following medical or surgical care should be considered or classified as complications. The provider must document all three of these. That must be more than a routinely expected condition or occurrence, must be a cause and effect relationship between the care provided and the condition, and must include an indication in the documentation from the provider that the condition is a complication. If the provider does not explicitly document that the condition is a complication of the procedure, then the provider should be queried for clarification.
Great. So I'm going to pick up here, and again, in theory, the slides will advance. There we go. We're going to talk about provider documentation and education. One of the keys here, and I think it's a key piece, it's not about what we are doing as CDIs, quality or coding professionals. It really has to start at the beginning. There is nothing worse than writing a very well-written query and the provider giving us a snarky answer. There's the word we'll use today, snarky. Well, everybody knows that that is common following this surgery. You're right, actually, Dr. Smith. I did know that, and that's why I'm asking the question. If we don't start out with good education, we're not going to get the right engagement, and maybe we can avoid a few of the queries. So what we want to remind the providers is for us to code a condition, first of all, it has to be documented by a provider, in the body of the medical record. And for us to report conditions, they have to meet one of the 5 criteria. So, many patients, for example, have an ileus after surgery. Well, yes, they've had general anesthesia or they've had, direct surgery on their bowels. But not every ileus extends our length of our stay or requires more care or monitoring. So not every ileus is reportable, shall we say. And I think it's a good reminder that why are we asking the providers? Because we need to figure out through their documentation how it meets one of these 5 criteria or doesn't meet at all and is not to be reported. Okay. And of course, the biggest thing that we want to remind them is what is the so what? We need to get the proper reflection of the severity of illness and that risk of mortality of our patient. We need to know how relevant it is. And again, we're trying to match not only the documentation, but the significance of the condition together to determine, again, whether or not it's reported. Okay. When are there times that we're going to need to query this, doctor? And again, some of this information we really believe you need to have as part of a standard deck in your annual education or for your new onboarding of your providers, especially for our surgeons, but not only. What is your intent of the term postoperative? Are you truly saying this is a complication from the surgery? One of my coworkers and I were recently talking about a very large hemothorax after a biopsy. Well, it is postoperative, certainly. It occurred after the surgery. Was his intended meaning it was due to the surgery or just occurred in the postoperative period? Sometimes, again, when it's ambiguous or conflicting, one doctor is documenting this as a device infection, and the other one says, nope, it has nothing to do with the device. Right? That I see that most commonly, like I said, the conflict is most often when we have multiple providers on board, and we can't pick who we think is the smartest or the most correct provider in their documentation. We're going to have to query on that conflict. Or when they say complications none, or they even document something as a complication at the bottom of the op note, but when I read the note, it didn't really seem that really extended your surgery. So, is that truly your opinion on this case? Okay. Types of queries, again, for example, if it is vague, status post ORIF now with the DVT, what does that mean? Is the DVT due to that previous surgery? That is so vague that I'm going to have to query that. Again, another opportunity, as we said, is when there's unclear significance of a diagnosis, or is it expected or integral? Would I expect you to have an ileus on day 1 after a AAA repair? I probably would. I don't know that that's significant for you to document. And again, that might be expected during this time period. Again, the third scenario is if we have an attribution of our event that seems to be unclear. Why do they have urinary retention? Is it due to the surgery? Is it adverse effect of anesthesia? Or is it due to neither? Is it because the physician can only urinate while standing, as an example? He cannot, urinate in a laying position. Well, I don't know that I would like to call that as a surgical complication when he is, not able to be mobile yet. And of course, as we said before, if there is documentation conflict either between the attending consultants or amongst consultants. Okay. What we remind the providers in our education is that a code would not typically be assigned for an expected condition following surgery when it did not persist beyond the expected time frame, there was no treatment directed toward the condition, or it didn't extend the patient's stay. Now, what's an expected time frame? I have this conversation all the time with some of our students and our clients. How long should an ileus occur after surgery? There's not a magic number. I know you will read out there maybe 48 or 72 hours. Depends on how extensive your surgery is. I would not expect an ileus for 72 hours after a simple hernia repair, an inguinal hernia repair, but I would expect it after a major Whipple. I'd expect it maybe 4 or 5 days. We need to have the providers determine did it extend beyond what they were expecting based on this patient and this surgery. There's not a blanket statement, and remind them I'm giving them back the power. I'm giving them the decision making so that we do know when it is appropriate or inappropriate to code this as a complication. And again, just because a patient has an ileus, well, I am usually NPO on that first day or maybe on just sips of clears. If that's a normal progression, if we don't alter our normal progression and advancement of diet, then it's probably not significant. Again, to remind the providers, when in the complication section, if you put something there, understand without a query, that's probably going to get coded as a complication because you did put it in that section. Okay? And we want them to not underdocument. And Audrey and I had this conversation yesterday. We are not trying to talk our way out of complications. By no means do we want anyone to think that's 3M stance. We want accurate reporting of complications or conditions and the clear cause. Okay. What is that role of the provider? Again, we need to hand that power back to our surgeons and our providers on the record. I think for many years, we did not ask questions where maybe a question might have been appropriate. And Coding Clinic came out with several coding clinics in the last 10 years that basically said it is the provider's responsibility to determine whether or not something occurred during surgery as a complication or expected outcome. And again, you'll see some references here that we have included at the end, that we are not supposed to make assumptions. We are supposed to query our providers. As an example, one of our generic query templates in our 3M software is this postoperative relationship query. And I do think over the years, this query has really grown and changed. Is it a complication of the surgery? And one of our consultant physicians that works with us says of surgery/surgeon to make sure they understand how that's being attributed. Condition occurred in the postoperative period unrelated to surgery. And again, making sure that they're telling us what it is due to. It might be opioid-related constipation as an example. Is it incidental or integral to surgery, right? I expect, based on those dense adhesions, to have a serosal tear. It is integral, or that much amount of blood loss is integral to removing this vascular tumor. So, and of course, clinically unable to determine. And we want to customize it specific to the scenario we're in and pick the choices that pertain to our scenario. We don't just use all of these choices in every single query. Again, we need to customize them, but we, of course, always have to give our providers an other and a clinically unable to determine. Now, we do want to point out a little bit of an issue. Our guidelines for achieving a compliant query practice that was developed by Hema and Actis was developed about 2016 or so, maybe 2012. It's been around a while, and they've had several updates, the last being 2019. In one particular section of the practice brief, what was new and added, that queries should not direct a provider to document a diagnosis that is not supported but serves as an exclusion for a patient safety indicator. Can very much agree with that. We should not try to get a pleural effusion documented on every single case to avoid the postoperative pneumothorax complication code. That's clinically not supported nor appropriate. Okay. The second scenario said queries should not encourage a provider to neutralize documentation suggestive of a post-surgical complication. Now, I can argue with that statement, and I will refer you, and 3M will refer you to the other portion of the practice brief. There is a recommendation that we should query when establishing or negating a cause and effect relationship between conditions, manifestations, etiology, complications, or conditions and diagnostic findings. So the two portions of the practice brief appear to contradict themselves. It's 3M's opinion that it's not inappropriate to query on the word postoperative when there is a clinically logical reason why the patient has a condition. Again, you need to decide in your organization and have policies and procedures about when it's appropriate to query or not. But based on this conflicting documentation, if you're doing it in a compliant manner, we think it's appropriate to clarify. And if we could launch our next polling question. Our provider documented atrial fibrillation status post-CABG It lasted 6 hours and converted spontaneously. Our patient was asymptomatic. What should we do, either as a CBI or a coder? When we see that in the record, what are we supposed to do? Should we just assign the code for the postoperative cardiac complication? Should we assign a code for regular AFib? Should we assign both the complication code and the AFib, or query for the significance and cause and effect and relationship? And hopefully, again, those that have chosen participate have had a chance. If you can please share the polling results, please.
Yes. Okay. Sharing the results there. So we had 1% for postoperative cardiac complication, 14% for AFib, 4% for both postoperative cardiac complication and AFib, and then 82% for query for significance and cause and effect relationship.
Great, thank you. So when you think about that, we would not, of course, like to just assign the complication code, because I believe this is ambiguous or vague documentation, whether or not this is actually due to as a complication of the CABG. As a former cardiac surgical postoperative nurse, so many of my patients had AFib. I don't think this is bad surgical care of our patients. Okay, certainly we would, want to be thinking about coding AFib, but is it a big deal? Is 6 hours a long time? We didn't treat it. Well, I don't know, right? And I should not be the judge and jury of that. Okay, we probably really need a query for the significance of this. Is this a significant rhythm? How did the patient tolerate it? Are we worried? Are we going to just prophylax them? And again, what is the cause of this AFib? Is it inherent or incidental in having a CABG, or is it a complication of the care? So again, we would have recommended, of course, the 82% of you that chose option 4, we absolutely agree with you, because I don't know how to assign this, and I need to be careful not to put myself in the judge's seat there. So what we're going to do is go through a few case examples of some different scenarios and talk about what our recommendations would be. Okay. So the first one is probably one of the most controversial over time. We had a large percentage of these being coded in previous years, and that has really decreased a lot, through some coding guidance we've been given from Coding Clinic and coding guidelines, but also through some information we've gotten actually from the surgical community. Okay, so what is the concern? Our laceration, tear, or enterotomy that happens during a procedure is not always significant. So if it's only a superficial, that serosal tear is only the superficial layer of the intestine. There are multiple layers, and that is the least. That's like getting a skin tear on my hand, as an example. And even when it is a significant laceration or enterotomy, it may not be avoidable. And what I tell people all the time is actually Google and look at some physical images of adhesions. And if you look at a few of those pictures over time, you can understand why there may be no way to not tear that bowel, because I can't see where the adhesion ends and the bowel starts. Okay? So again, when should we query? Again, we need to ask, is it clinically significant, yes or no? You had a serosal tear and you put a stitch in. Is it a big deal or not a big deal? Or again, if you are noted as a complication, but it seemed to be only one stitch was put in there, how much did that compound the surgery, extend the surgery? How significant is it to the patient long term? Okay. And of course, the biggest recommendation is to quote exactly what they've already said in the record and give them options. Okay. Now, you would not use the part that says omit code, et cetera. That is telling us, based on the provider's response, what would be the code assignment. So if the option was, if the provider chose the tear was not clinically significant, we would not code that enterotomy, that laceration, I should say, and nor would we code the repair. The option, if he said it was integral and could not be avoided, again, same thing, we would not code both the diagnosis code nor the procedure code for the repair. If the provider did note it was a complication of the surgery, we would assign the code for the laceration and, of course, the procedural repair, and is always other and able to determine. The other thing that I will tell you is I have worked with providers not only at the bedside, for over 30 years, but in this role for 11 plus years, I find more surgeons are more honest than we give themselves credit for. And even if they are dishonest, that is something you have to escalate to your leadership. We don't code based on what we think they're trying to do or not do. Again, code assignment is based on your documentation for each individual case. One of the things that Audrey and I sometimes catch ourselves doing is trying to make too general of a statement and say we would or would not do something. No, based on the case we're reading today, what is our advice and recommendation? I jokingly tell her that invisible Audrey is always sitting on my shoulder saying, no, let's think about today's case. What is our option? Okay, so in this example, the op note said complication, serosal tear in small bowel. I don't know what their intent is. Are you intending to deem yourself as a complication? By filling that in, it appears that you are. But, maybe the provider doesn't understand that what happens when they're filling that information in that section. Okay. What about an additional procedure other than a simple suture was done to treat the laceration? We might have had to call in, because we tore the bladder, we might have to call in a urologist to repair, right? Or we might have done an additional evaluation. We might have actually done an EGD to see, did we have a through-and-through injury to the stomach? Do we have to resect or excise additional tissue? Like I said, depending on your patient's scenarios and based on that operative note, it might be appropriate to query for the inherency. Okay. Now, if there does not seem to be dense adhesions or multiple surgeries on our patients in the past, again, on a case-by-case basis, I may not be querying for the inherency. In other words, it is what it is. But again, we need to be very careful not to be judges and let the providers know, maybe they can actually avoid a query by explaining, during the surgery, an unavoidable laceration occurred requiring an excision. No query needed because that he clearly said. Okay. Moving on to our next category. It is postoperative acute respiratory failure, another scenario. Okay. What are our concerns? We do understand that sometimes the patient is on a ventilator because of the procedure. We have had to anesthetize them for so long that it's going to take them time to wake up to where they're strong enough to breathe. Understanding that our intensivists, our anesthesiologists, our critical care physicians monitoring that patient do not know that they have been coding this as a complication against that surgeon. And again, this last statement comes from Dr. Wolf. It really is uncommon that respiratory failure after surgery is actually a complication of the procedure itself. Okay. Audrey, look, my mouse, there it goes. One to query. Again, you have two basic scenarios. If the patient has clinically valid respiratory failure and it's not been documented as such, we need a query, right? Or if we do have postoperative respiratory failure in the record, I don't know if it's actually due to surgery or not, So, and really the third is when it's documented and it's not even clinically valid. Again, we want to put the clinical indicators supporting our diagnosis, include options again, such as integral to the procedure or due to another condition. And do note that if the provider does note it is due to another condition such as COPD, we do have an excludes note, which means that we can't code the J9582. We'd have to code the respiratory failure and other conditions. And again, we would give them the option of a complication other and unable to determine. And here's a query example. In this patient, he had a cabbage and valve. He came intubated 0 day, so his surgical day, the intensivist noted the respiratory failure, but he was extubated shortly after arrival to 2 liters without difficulty, which is really unusual and really good for the patient. And you'll notice that his respirations look good and his saturations are fine. Later in the day, he is only down to 1 liter and setting even 98%, again, looking good. What was the patient's respiratory status after surgery? Did he have routine ventilator management incidental to the cabbage? It was present in a complication, or was present due to some other condition other and clinically unable to determine. And of course, in this case, it doesn't even appear that the patient has any degree of respiratory failure. Postoperative ileus. We've talked about this a few times, and again, we'll reiterate this again. When the provider is saying postoperative ileus, automatically our brain is wondering, should we be assigning a complication code? And we really want to not just take that word at face value and slap the code on and move on. Okay. Again, could this be integral or expected at that point that it's happened based on this procedure, right? Based on the type of procedure I'm doing and at what point in the postoperative stay or timeline is this occurring? And if it is beyond what was expected, so no, I wouldn't expect an ileus far out. Is it truly a surgical complication or is there some other cause? And you'll notice, sorry, as it starts clicking, we always include our indicators and again give the same similar, oh, sorry, I clicked too far ahead, similar characteristics such as integral to or during, due to patient characteristics. Don't just use that choice. Due to, patient morbid obesity, patient's inherent Crohn's disease, is it due to their use of narcotics, things like that. And of course, and give clinically unable to determine and other. Okay. Again, what would be normal? Well, pretty much everybody is going to have some decrease or lack of bowel function after surgery. In some types of surgery, you would have an NG tube for 1 or 2 days, again, the more extensive ones. And typically an ileus, for the most part, resolves within 2 to 3 days. When we change what's expected for a normal patient having this surgery, leaving that NG tube on beyond those 2 days, or reinserting one, or placing one, or moving backwards on our diet, right? Starting back over, that would not be normal. I had a chart once where the patient had an ileus for 3 days after a cholecystectomy. Well, that's not normal and expected. And she should have gone home maybe in 24, 48 hours afterwards, and she stayed in the hospital 5 days. That was beyond what was expected. And of course, I love this scenario that was given again by our consultant friend, Dr. Wolf. You can see this patient has Crohn's disease with chronic fistulas, chronic infection, and had a cecectomy. You'll notice on post-op day 2, she's not doing well. Post-op day 3, she does seem to have some sort of ileus. On post-op day 4, she is advancing. Day 5, doing even better, and went home on day 6. Is this ileus integral or incidental to her cecectomy? Is her ileus due to her Crohn's and her chronic infection? Is it due to the opioids that we had prescribed for her surgery? Complication of the procedure due to the surgery or surgeon, or due to other? Now, again, in what order I would give these options, there is no particular order. In other words, we're not saying pick your favorite choice as principal. We're just listing the different options that you would want to include in your query. Okay. Another kind of hot button type of complication is our postoperative hemorrhage or hematoma. Okay. Not all bleeding is significant. It could be clinically insignificant, or again, it could be inherent to our surgical procedure or a complication. Part of this is doing your homework way in advance and knowing the type of surgery and asking your providers. I got educated on spinal fusions. What was a normal amount of blood loss following spinal fusions? The more levels that I fuse, that's the more vertebrae I'm cutting through and cutting those bones, right? And because of that, they're going to have a lot of bleeding. They said for a 3 or 4 level fusion, it was not unusual to have a liter of blood loss. Wow, that was enlightening to me, right? I didn't realize that would bleed that much. I would know that a vascular tumor would bleed that much, but didn't understand that. So do your homework in advance before we even decide whether or not we're going to start asking questions. Okay. Again, if my significance is unclear, so patient had some bleeding during the surgery. Well, that doesn't sound very clear. How significant is it? Okay. Or, whether he suddenly now has, hematuria. Yes, ma'am. Yes, ma'am.
I just wanted to, your reception is getting a little crackly. I didn't know if there was anything that you could do to correct that. Can you hear me? Cheryl?
Yeah, you sound crackly, but I sound clear to myself.
Oh, goodness, did we lose you altogether?
Around a little bit. Yeah, I'm here. Can you hear me? No, I'm here. Can you hear me?
Okay, then maybe I'm the one that's crackly and everything's fine. Please go ahead.
Yes, no.
Yes, I can. Please go ahead. Go ahead.
Thank you. Okay, so again.
Yes, please go ahead.
Thank you. Okay, so how do we query again? Great. We are going to identify our indicators on our diagnosis file. We have a delay here. Sorry, everyone, for our technical difficulties. Like I said, ask what is inherent or expected or what is truly a complication. If this mouse is going to go forward here. And this would, how do we code, by the way, postoperative hemorrhage? interesting. We had some recent coding clinic advice on this, and I found this really interesting and informative. And I really like when I see this sort of update because they're giving us clear guidance so that we know what to do with this. So in this particular case, the final diagnostic statement said the complication of intraoperative hemorrhage at the orifice of the cystic artery during a cholecystectomy. Okay. In other words, how do I code that when it was an arterial bleed? Do I code it to bleeding of the gallbladder or a bleeding of an artery or injury to the? And you'll notice they said it's the digestive system or organ. Okay, so it was the gallbladder. Okay, because we know that the body's organs are vascular and bleed when they're cut. Okay, and you'll note if a vascular procedure is done on an unrelated vessel, or if the injury involves an unrelated vessel not attached to the organ or does not supply that organ, we would do a hemorrhage of the artery, the injury of the artery, the hemorrhage of the artery instead of the gallbladder. And again, you'll notice that this is brand new coding clinic advice from first quarter 2020, pages 19 to 20. And like I said, I think this has been one that had seemed maybe confusing at times, and I like this very clear guidance. So Audrey, hopefully you can hear me, and I'm going to pass the baton back to you.
Yes,
we'll give her
I
a minute.
got it. I got the baton, and hopefully you can hear me.
She doesn't
I
join
will continue on this slide. Cheryl, I am here. And on this slide, we are going into some of the different types of devices, implants, and graft infections. Because I was saying earlier that there were so... Okay, Jared, can you hear either Cheryl or I? And I may be on a huge delay.
Yes, I can hear you both, but the audio is.
Okay, then.
Yeah, we're getting. I'm looking at the comments coming in, and it's a mixture. Some are saying they can hear you both just fine, and some saying it's very choppy.
Okay. Now. Okay. I'm on the choppy end of it probably. But Cheryl, if you're okay, then I'm going to keep on going from here. And now even Jared was sounding a little crackly now when he was sounding very clear at the beginning. This slide 40, we're going into some of the different types of device infections. As I was saying earlier, there are different types of codes that are available depending on where the infection is and what type of device was involved. The reason I'm pointing this out is because the difference of code assignment could make a difference on DRG assignment, or where it will go to. And it also could have an impact in some of the quality metrics. So it is important that we do identify and classify it to the right code. You'll see on this last slide here, the last bullet point about a UTI and or sepsis due to a Foley. And there are a couple of coding clinics that are related to this. The fact that a patient has an indwelling catheter and is noted to have a UTI or sepsis does not make an automatic link between the two, between the device and the infection. The provider must clearly document the causal relationship before infection due to urinary catheter can be assigned. And so if the documentation is not clear, then the provider should be queried for clarification. Because once again, you need that clear documentation of a cause and effect relationship. There's also a couple of different codes related to line infections. So you have a central venous catheter. That could be your PICC, your Hickman, your Portacath, and so that's going to be a central venous catheter, and you will have a code that will be related to that if it's a systemic infection, so if it's a bloodstream infection, or if it's at the exit or insertion site infection. So just note, you'll want to know from the documentation, was it a central line infection or was it a midline? Because a midline would go to a different code as well. So infection due to other cardiac or vascular device would include your midline, or a renal dialysis catheter that is not a central venous catheter. So if your renal dialysis catheter is a central venous catheter, then you'll go to the codes for the central venous catheter infection. Now, Cheryl, if you can hear me, I'm going to pass this back over to you. Let's see if we can pass this baton carefully.
Yes, ma'am, I can hear you. Absolutely. So, postoperative complications.
And if not,
and again, hopefully everyone is hearing me.
Please go ahead.
One of the things that Audrey and I had, and I'm going to use the word debate. Oh, Jerry, can you hear me? Yep. Now, you definitely have a delay. Postoperative complications. One of the things that Audrey and I debated, and we had some,
Yes.
we'll call them intense conversations. Some people could call them drag-out arguments. But you'll notice that we're still alive. No blood was drawn, and we're still friends. One of the things that we want you to think about is really and truly, we know that there are codes that are assigned to different code ranges, right? And we know that we can get to a code when we go to the code book. What we want us to remember is look at each chart and make a decision on each chart on how we need to approach them. So if you'll notice on this particular slide, the following will be coded as an intraoperative or postoperative conditions. Anything that happens during surgery, okay? Those complications of operative wounds, because they wouldn't have a wound if we didn't do surgery. Complications that are documented as due to that implanted device, whether it be infection or a mechanical malfunction. Do note that ileus actually has an instructional note underneath there, okay? Infection due to a procedure, again, they've linked the infection to the procedure. We talked about the significant hemorrhage or hematoma during surgery, and the same with the significant lacerations or arterial dissections. Okay. And then Audrey, if you want to try and do this slide, the last two.
Absolutely, I will take it from here. Will do. There is, you know, when we are talking about it, most of the time there will be, we need to have criteria being met regarding the coding if it is going to be classified as a postoperative complication. We did discuss this on earlier slides, and these are some examples that will be classified as a complication if the physician, the provider, has documented that is more than routinely expected occurrence, or that there's an indication in the record that it's more than a routinely expected occurrence. The provider has documented or established a link between the condition and the procedure, and if the documentation indicates that it is a complication. Now, as I was saying earlier in the guidelines, this is all true. You need to have a cause and effect relationship. The physician will need to give that indication that it's a complication, but unless there's an indication, unless the coding classification system directs us otherwise. And there are times that in the index, in the code book index, it will say postoperative or post-procedural. And in that time, it would be, you're allowed to assign it to that complication code. However, that debate that Cheryl was talking about, that she and I have had on this, it's that just because you're allowed to code it that way, do you necessarily need to, is it necessarily right to go that way? And so you still may need to get clarification regarding the condition and if it is related to the procedure. Once again, every case needs to stand on its own merit. You need to evaluate each individual record individually. You will take the guidelines and you can apply the guidelines, but you need to make sure that it applies to the particular case that you have. And so you're always looking at all of the documentation that is in the record. Is the documentation overwhelmingly telling you that, yes, this is a complication of the procedure, and then a query is not necessary? Or is it that vague or ambiguous documentation that you will need to get that additional documentation from the provider to help support the code? Because what you're trying to do is to make sure that you are accurately and completely coding that record. You want to make sure it is accurate because of all the implications that it will have. Now, as we stated, there are times that the coding will allow you to take that, but is that the intent of the record? Is that the intent of the documentation? Is that what's really going on with the record? So you want to evaluate each case individually to make sure you're applying the correct guidelines. This last slide is going into some of the some conditions that, when documented as a post-procedural or a post-operative type of a condition, it would not go to a complication code per se, but some of the external agencies are still counting some of these conditions as complications. So once again, we're wanting to make sure that we apply the codes correctly and that we're accurately classifying the correct code to the intent of the provider's documentation. At this time, Jared, I'm going to turn it over to you, hopefully, and see if there are any questions that are coming through, and if we can survive these technical difficulties we're having.
Awesome. Yeah, and again, we apologize for the technical issues. We're doing the best we can on our end to resolve that. So, but with that said, let's move into the Q&A portion of our webinar. So if you'd like to submit a question, you can use the questions feature in your web meeting controls located in the lower right corner of your screen. And then additionally, if you would like more information about the topics in this webinar, I'm going to launch a poll here, and you'll be able to select from 3 options. And while we're doing that, I just wanted to go over a few reminders. We have a PDF that contains all of the presentation slides, and that's available for you to download. It's located in the Handouts section of your web meeting controls. We also recorded today's presentation, and a webinar archive will be available. So look out for an email from the next week that includes a link to the archive. Lastly, we'll also provide a certificate of attendance to webinar attendees, and that will be emailed to you upon the completion of this webinar within a few hours. Okay. I'm going to go ahead and close out that poll, so leave it open for just a few more seconds. Okay, so first question here. Our providers state that any electrical abnormality in regards to a cardiac surgery is expected in 24 hours. We would like to query suggestions on how to mitigate.
My question is why we're querying. The provider is giving you a blanket statement saying the electrical abnormalities are expected within 24 hours of that surgery. And again, I'm assuming cabbages and valves, or any of those cardiac type of procedures. I would not disagree with the surgeon, first of all. I'm going to give them that. The question is how to mitigate. Well, first of all, if it's expected, then why doesn't the provider note expected atrial fib following procedure? In other words, work with your EMR templates and see if you can create some custom templates for the providers, or remind the providers to document that. Or first of all, our goal is to not have to query, right? To make the documentation so clear that we can modify their documentation. And we know that group of doctors doesn't like queries on a good day, right? Okay, so, that's the extra incentive there, is to remind them, you don't like to be queried. Here's how you can avoid our queries in the first place. I need this type of language. One of our providers, when they thought acute blood loss anemia was a complication, they expected acute blood loss anemia on all their charts. Fine. That is telling me that I don't need to put a complication code on there. Okay? The only thing that we might then struggle with is, I know it's expected, but is it significant enough to assign any sort of code for that electrical abnormality, such as AFib? That's where we're going to have to look at the treatment and the monitoring. Do we give every single patient amiodarone after their cabbage? Do we give it to them orally? Do we give it, do we start a drip? That's really going to be dependent. And I think that's where you have conversations with the providers. And again, getting them to not use the word post-op, first of all, right? And maybe just call the arrhythmia an arrhythmia. Patient developed AFib. Okay, great. Now I don't have a question whether or not it's a complication or not. I think those are a couple of avenues. In your query, again, I think you have a standard template that says it's an integral inherent, is a complication of the surgery/surgeon, and understand you're going to get some pushback in the beginning, and it's understandable.
Awesome. Okay. So another question here. I am not a coder, so I have a big question. I review PSI records. Are you saying in order to... Yeah. Sounds like there's a little bit of a delay. Are you able to hear me, Cheryl?
I can. You said, you said PSIs, and you said in order to, and that's where you broke off.
Okay. I'll just pick up from there. So are you saying in order to use the code of respiratory failure, the MD must state the failure was a complication of the surgery, or that a DVT was a complication of the surgery? To assign the J9582 code, the respiratory failure following surgery, postoperative respiratory failure, take those words out of my mouth, post-op respiratory failure, they would have had to say that it was due to the surgery, right? They're going to say this is a surgical complication for us to assign that. And again, typically their documentation of postoperative respiratory failure, I can go under respiratory failure and see a code for the word postoperative.
The question is whether or not it's clinically valid, first of all. Secondly, again, what is its cause? And the way to mitigate this is, again, to determine where our problem is. It's either a valid complication. I shouldn't have respiratory failure following an inguinal surgery repair without any medical comorbid conditions, okay? So is it valid, yes or no? And then what is its cause? And again, the best way to mitigate this is by having our providers change their language in their documentation instead of just documenting diagnosis. Post-op respiratory failure due to his pre-existing COPD. We know what codes are assigned, and we know what codes the coders would assign. Okay? And I think, again, the struggle here is it's making the documentation match the clinical truth that's in the medical record, and either looking for that documentation that supports the clinical truth or matches the clinical truth, right? Looking at the documentation in the picture and saying, do we have a match or not a match, and where is our problem? Is it the diagnosis doesn't exist, or that there's another reasonable explanation for it? But I don't want us to think that we blanket query out of every single complication after surgery, because that would be inappropriate to blanket query to get rid of all of them.
Great. Okay. Thank you. I think that's all the time we have today. So if we didn't get to your question, we'll make sure to follow up with you via email. And with all the technical and audio issues, just a reminder again that we will be sending out a link to the archive. So look for that in your inbox in the next week. And we'll also be sending you a certificate of attendance shortly after this webinar. Cheryl and Audrey, thank you for this excellent presentation, and thank you all for joining us. This concludes today's 3M Health Information Systems webinar.